Thank you. Thank you very much. I'm thrilled, honored to be here with luminaries and such a distinguished and eclectic group. Just to echo what Liza said, that pain management's a team sport. And what I'm going to do in the next 15 minutes, if I can get through it all, and I'm going to go through it pretty fast, is give you a sense of where we are on the education front. And I think you'll see that we've made some interesting advances over the last 5 years. I have no financial disclosures. So I'll just pass through this. All of this is really based on the disturbing discrepancy that we have so many people in pain, and we use most of the world's pain relievers, and the two don't go together. And, we have to ask ourselves why. I think there are a lot of reasons, but one of the reasons is the education gap. And again, I'm going to be able to go a little faster because I've already told you some of this in my statement before, that every group that's looked at the problem of inadequate or inappropriate pain management has recognized that we have an education gap in our pre-licensure and our post-licensure clinicians. And again, it's a team sport, and it's a team problem. It's a problem across all professions. Now, the one profession that has done best are the veterinarians. Judy Watson is here, and this is her study. She'll be speaking, I think, tomorrow. And this is one of the great magazine covers from our field, that your dog can get better health care than you, based on her pain survey. So I wanted to pose this question: why do we have an education gap? Pain's the most common reason a patient goes to a clinician. We train all of these clinicians. Why don't we train them about pain? One of the big problems are the silos. We're not only siloed interprofessionally, we're siloed interdisciplinarily. Pain's a part of all of the clinical disciplines at the curriculum table, but it's not the primary focus of any, which I think is a main problem. But, we've been working on this for years, and as a field, I must say we have failed. One of the silver linings of an opioid crisis is that now there's attention to the problem. My fear is that the solution will be to train new clinicians not to prescribe opioids, which is not our goal. Our goal is to train our clinicians so that they're competent at recognizing, treating, understanding, and working within the context of how pain presents to them. So, I put up here, is it because we don't care? I think there's great evidence that we do care. This meeting would be refuting evidence that we don't care. Are we not trying hard enough? We've spent 30 years as a field trying to make one novel curriculum after another, and there's no uptake. So I would suggest to you that the problem is that we don't have the right approach. And this is an article that I wrote with Heather Young. It's a plug for our funders, and it's basically, our quote is, if you don't know where you're going, you may not get there. And really our idea here is that competency and competency-based education, I think you've all heard of. This isn't a plug for competency-based education or a talk about it. It's very complicated. It has dubious traction. But the issue here is that we're talking about competency in terms of goals. And goals are important. So I wanted to just go through this little algorithm that I took the top line directly from the description of this conference, which is that we're focused on non-pharmacological treatments and integrative health models for pain management. So if we're interested in those models and we're interested in the clinicians who will embrace them, I assume there's no one here that would be opposed to educating those clinicians, right? They need to be educated. To educate them, we need to approach that education uniprofessionally within their professional education and interprofessionally, and I would say there's probably a multi-professional category in the middle there as well. And the expectation is that they come out, no matter what profession is going to touch a patient in pain, that they're competent to treat that patient. I don't know if anyone would disagree with that. That's the goal, that they are competent. And to do that, we need to recognize education's important. What we often do is we skip the goal and we go straight to the curriculum, and then we skip the competency at the end. So this is really about putting that back in, and that's where I think we lost our compass. Again, if you don't know where you're going, if you don't have a goal, you may not get there, and I think that's what's happened over the last 20 years. So we endeavored at UC Davis to bring together a national and international group of experts to look at what are the essential core competencies that we would expect of any graduate of a pre-licensure health education program, not medicine or nursing, but the whole shebang. We brought pharmacists and acupuncturists and physical therapists to the table, and we argued for a few days. We went into a pretty dark black hole, and what we came out with was the recognition that no one agrees on curriculum, that teaching is an art, and everybody does it differently. But there's a good deal of consensus around the idea or shared beliefs about what our students should come out with or be able to do. So this is what we came up with. And again, as Liza had said around the interprofessional competencies, we have 4 domains with a lot of competencies within them. But what's really held up is this model of every student that graduates from a health professional program ought to know what pain is, ought to understand how pain is recognized, ought to be able to understand how it's safely and effectively treated within their scope of practice, and particularly, and I've heard this in many ways from many of the speakers today, they need to understand the context in which pain presents. And what we found is that this construct has held up. It's been embraced by many different national and international professional organizations. And there are other competencies that have come up as well, mostly around substance abuse and opioid prescribing. But I'd argue that model of what it is, how is it recognized, how is it safely and effectively treated, and how does context affect it, applies very nicely to all of these other competencies that are emerging. So we have somewhat of a unifying view of how to look at that student who's graduating and how to look at the professional even in their post-licensure education. We were fortunate to be invited by the National Board of Medicine because of the competencies to review the USMLE, the U.S. Medical Licensing Exam, the one exam that every physician has to pass to be able to get a state license. And I'm not going to go into detail about how we did it. There are several people in this room who were part of this a survey group. Basically, in 2014, we went to Philadelphia as a group of 12 experts under observation for 2 days and reviewed actual exams. We got through about, 1,500. We went in with the hypothesis that pain is not covered in most medical curriculum. It probably won't be much on the test. We were wrong. It was all over the test, largely as a descriptor, but we found that 15% of the USMLE partially or directly tested on pain, which we thought was quite substantial. This is really the money slide here, what we found. Of that 15% of the questions, 90% of them focused on recognition of pain. And you might ask, well, why are they testing solely on that? And really, and again, this is based on breaking it down by the fractal competencies, and 80% were using valid and reliable tools for measuring pain. So I think the story is here on this slide that, what is required of clinicians? They're not required to do pain management or to know about pain management. They're required to recognize pain. And this is actually a slide I'm sure you've all seen of the epidemic of unintended overdose deaths with opioids. And you can see the year that the Joint Commission Pain as a Fifth Vital Sign was started as the inflection point for the rise in opioid deaths. And I really want to emphasize that this is not a criticism about recognizing pain, although some of our regulators have thought, well, boy, all we have to do is stop recognizing pain and we won't have a problem. So this is a serious problem. But the recognizing pain which is really one of the four domains, without understanding pain, understanding how to treat it safely and effectively, and understanding its context, may actually create a perfect storm where uninformed clinicians reach for what is known and accessible. So I wanted to stress that. And again, as a research priority, this is something that we can explore, particularly from a medical economics perspective. I think that this costs us a lot, and again, not to throw shade at recognizing pain, but this is really the finding that we had. We need to make sure this is known and followed up, not just in medicine, but in every profession that's part of the team. So this has to be addressed not only in pre-licensure training, but also post-licensure training. The problem is that I think if we can get our accreditors on board, we will change pre-licensure accreditation. Unfortunately, the accreditors believe that they're already teaching pain. And there's a lot of confabulatory literature out there to support that without real evidence. So I think it's our job to make sure that the accreditors are on board. This is a national problem, and I think a national priority. But once we change curriculum for our professional health students, we still have generations of clinicians out on the front line, particularly in primary care, without training. So this has to be addressed, and this is a problem in and of itself that can't be addressed purely through changing the goals of education. I wanted to mention something that we're doing at UC Davis, and I think we're the only program that I know of that is looking at retraining primary care clinicians as a fellowship program. We started off doing ECHO. Many of you may be familiar with telementoring, and we were reaching out on a weekly basis, not to individuals, which is how ECHO was traditionally done, but to the teams that take care of patients in primary care. We contracted with them for 6 months to a year, and our hope was to improve their primary care pain practice, and we found that it changed dramatically. The problem is, and what we also found is that it was paid for subsequently by the insurance companies who saw the return on investment. What we found, though, is that we didn't have enough time to do all the ECHO work that was needed. So we started this Train the Trainer Primary Care Fellowship. We're in our second year now, and the idea is that we're training the ECHO leaders or the trainers for each primary practice that they come from. Our hope is to show return on investment here, and anyone who wants to fund a medical economics study on this, I'm here to talk to you, because we think that this is going to get scaled nationally or statewide, and hopefully nationally as a solution, because there should be a trained person in every primary care practice for some time to come until the next generation, the next swell of clinicians are born. Liza mentioned that I run the Center for Advancing Pain Relief. I wanted to mention that as well, because this is actually not a center in a sense, it's an uncenter. The goal of it is to bring down those silos and to start connecting different professions and areas within our university as a model for synergizing the scholarly and academic work that we all need to do. So the bottom line is that, I mentioned in my comment that I'm not sure the problem is that clinicians are taking the easy path. I think they're taking the ignorant path, but the only path they know. And we have to change that and find ways to do it. I love the quote from Dr. Churkin, who you see is what you get. We do what we know, and we need to change the fact that we know so little about all the different professions that we work in. We need to assure that our clinicians are competent, which means going after the testers of the students and going after the accreditors of the schools. And then I just wanted to say one more time, pain education should be a research priority. And with that, I thank you very much.